Good afternoon, everyone. We will try to keep you away from your postprandial snoozes. I'm Bill O'Neill, and you met Greg Stone, and delighted to have you here this afternoon. And we're going to go ahead and start with the program. So, Brad, you want to introduce the first folks?
Sure. Well, we're going to start with the debate. And, as I reviewed, what we're doing in Recover 4 is applying a very specific set of cath lab practices and pre-cath lab and post-cath lab practices. And we obviously don't have randomized trials for everything, so we don't know if that's correct. And we're going to explore one of those in this first debate. And this is about a watchful waiting. So for protected PCI, should the device be placed prior to intervention, or can it be on standby only if necessary? So Saras is going to take the stance that a device should be placed prior to intervention.
Good afternoon. Thank you to the organizer of Houston Shock for having me. I'll try to do my best in these 7 minutes that I have. If I can change slides. All right, these are my disclosures. None of these are relevant to today's discussion. So the objectives, I'm going to briefly present 2 cases that I'm going to wrap up at the end of the talk to show you contrast in how decision making can be challenging in the cath lab going on to the cardiac ICU. I have 3 arguments or 3 positions to take. Talk about ventricular unloading, talk about the impact of revascularization techniques, and the hemometabolic cascade. So these are the 2 cases that I'll show you. Both were my cases over the past year. 76-year-old male with hyperlipidemia, tobacco abuse, borderline blood pressures, comes in with a clear anterior STEMI on ECG. Some signs of early heart failure, as you may expect. These are his lab work. Lactates largely normal, everything else is acceptable. His EDP was 41 on cath, and I'll show you his films. So these are his films. The right's large, non-deceased, thrombotic proximal LAD, disease extending back into the left main, into the circumflex. And that's his LV gram with an EDP of 41 and an EF that's 30 if you're being generous. Keep this case in mind. This is case number 2. Young male referred to me for elective circumflex CTO PCI after an anterior STEMI at an outside medical center. His vitals were largely stable, still had some S3 gallop by basal repetitions. EF is down in the LAD with the LAD territory continuing to show regionality. Labs are okay. And I'll show you his LAD STEMI pictures in a bit. This is his deceased right, which was treated prior to the circumflex CTO. This was the outside films for the STEMI. As you can see, prox LAD, the operator balloons, the wire is going in different places. He or she keeps ballooning. There are dissection flaps in the mid LAD. There's a hand across the chest, which is never a good sign. They keep ballooning further down, eventually pave the LAD from prox to all the way distal. They save a spot where the diag comes off and they don't stent it. Has okay-ish flow, comes to me for CTO PCI. His radials are a toast, so I go up through his right groin, try to fix his RCA, and then there's a huge dissection retrograde. So I stop, pull out, watch him, does fine, bring him back in about 8 weeks to stage his RCA. Take a shot of the LAD before going. As you can see, continued poor flow. Just the part where the stents are is where it's plumpest. Everything else looks strange. And I'm an interventionalist, so I'm showing you these pictures for a reason. I'm not doing a show and tell just because I like to do one. And then I fix his right. We bring him back for the circ CTO. And I put a protection wire down the LAD, 7 French guide down from the left groin, which is the non-dissected groin. Go up, and then you see that picture on the top of the LAO caudal frame where you see that LAD diag bifurcation looking hazy. And I said, oh no, so I flipped it cranial and I took a picture, and sure enough, you see a very bad looking bifurcation where the old LAD STEMI was. So for audience poll, a quick show of hands, I don't have a clicker. How many of you would want hemodynamic support in this case? How many for vasoactive medications? How many for IABP? Case 1 or case 2? How many for impeller for case 1? Impeller for case 2? How many for bailout MCS only, which is going to be my opponent's argument? And again, this is another question. I'm not going to take polls, but I just want you to ponder, do we know what the right sequence of events is when we care for these patients? How do we do the various steps of the choreography in the cath lab? So my three arguments: LV unloading. This is from Dr. Stone's work. It's phenomenal that he's sitting here while I speak about his work. But as you know, infarct size is directly proportional to future heart failure events. And this is well established. There's a reason why we do primary PCI as quickly as we can. These are data from our group where we looked at AMI shock from the Optum Labs data set. And as you see, one of the most common reasons for readmission after shock is heart failure in the long term. Well, there are preclinical data and clinical data from the Door to Unload trial and preclinical work from Dr. Kapoor, which has looked at infarct size and LV unloading. And what I want you to understand that LV unloading by itself is a primary mechanism for decreasing infarct size, independent of achieving TIMI3 blood flow in the epicardial coronary blood vessel of choice. And that's what these preclinical studies showed. And then you talk about coronary perfusion pressure, which is the gradient between the MAP and the EDP. So the higher the EDP, lower the MAP, which is often true for Sky Stage B, going on to see kind of patients. They don't have much coronary perfusion. So lowering the EDP is a very effective strategy for these patients. This is Dr. Azzolini's work that showed that higher the EDP, worse the outcomes in this population. So, and you recruit your collateral blood flow, and if you heparinize these patients with data from Europe that shows that by the time they come to the lab, some of them already have their arteries open. Impact on revascularization, I'm not going to belabor the point too much, but essentially these patients are complex. They have multi-vessel disease. They have all the right risk factors in the right setting. And therefore, when they come to you in cardiogenic shock, they often have CTOs. They often don't do well if they have advanced BICS jeopardy scores. And therefore, that influences how we PCI these patients. If we do not do a good job with our hemodynamic stabilization, we often do not do a good job with our PCI because we are in a hurry to get things done and get out. These are PCI techniques with and without impeller. As you can see, more number of stents, more complete revascularization. Again, fully cognizant of the culprit shock data that says that we should stent the culprit only. This is residual syntax score telling us that if we don't do a good job, these patients have worse outcomes. These are data from our meta-analysis that's under review telling us that IVUS has better outcomes no matter which patient population you look at, and that's definitely true for the complex subgroup of cardiogenic shock. The hemometabolic cascade, there are a plethora of data that say that these patients do really well if you get impeller pre-PCI or MCS pre-PCI. But why is that? Well, that is because A, we are very poor at shock recognition, and this has been talked about. Unless we see a critical blood pressure of a MAP of 40 or a systolic of 60, we don't think of it as shock. And we know that hypotension and hypoperfusion has worse outcomes. This is just a review article where we talked about the different kinds of vasopressors and how they're represented in trials, and they're very poorly represented. And we know that higher the vasopressor therapy, the worse these patients do. So you're dialing up pressors, but you're not calling it shock. And so that's kind of the message I want to communicate. So with MCS, timing, it's important that we give early upfront MCS, arrest the hemometabolic cascade so that we prevent organ failure in these patients. And because once organ failure is manifest, immaterial to what you do with the central macrovascular hemodynamics, these patients do poorly. So I only have 20 seconds. So the first case did great, did put an impeller, did a DK crush of the left main, did fine. But in the ICU, shot up all his biomarkers, dropped his urine output, shot up his lactate, and didn't make it. The second case, I said, let's do bailout MCS. I said, oh, this is a simple bifurcation. Let's do a bailout MCS. Put a wire down the diag, put a wire down the LAD. But the reason it's important to see in this case is every time I balloon the diag, his LAD shut down, and every time I ballooned the LAD, his diag shut down for the simple reason that he had multiple dissection flaps from that STEMI that he got outside, which is consistent with the dissection he had in his aorta and dissection elsewhere. He was very prone for whatever fibromuscular dysplasia reason. So I stented his diag with the intent of doing a DK crush, lost flow in the LAD because the flap closed it shut, and then couldn't, tried really hard to balloon, in the middle of which you see CPR, you see an impeller device, you see VA ECMO going up, and then ended up stenting the LAD, which shut the diag flow down, and then there was, I can't confirm the flap, but the fact that I had to use a Confianza to puncture that stent into the diagonal and then drive a Mongo down, sure enough makes me feel that we did really have a dissection flap there. And the reason this diag isn't any other diag is because it is collateralizing that circumflex that was the CTO that was initially supposed to be the vessel that we needed to work on. So in summary, going back to this patient, he did great. He actually had multiple decompensations during this hospitalization, ended up getting an inpatient VAD and was dismissed. So there are multiple levels of understanding here. There is a level of understanding the coronary anatomy, coupling that with the hemodynamics, coupling that with their state of decompensation or otherwise, and then using all this information to make a decision about MCS, which will then impact your revascularization strategy, which will then impact a lot of things, including whether or not they develop cardiac arrest, whether or not they continue to do well. So in summary, I'm a great proponent of MCS use early upfront because it helps us as physicians caring for these patients on the cath lab table to do a good job with what they were initially there for, which is to fix their coronaries and help them get out of this whatever coronary catastrophe they're dealing with. Bailout MCS, though very, very attractive, is often a flawed opinion because there is no good way to tell, as you can see from these two cases, as to when the right time to put an MCS device is. With that, I thank you for your time, and I'll be happy to take questions.
That's a wonderful way to start. So we'll go ahead to the counterpoint, and then we'll have the two of you come back up, and we'll ask some questions.